We'll go ahead and get started with the last session of the day. This is going to be infectious grooves, get on the soul train, but we're going to take a step back, although this fits right into it. Chris Attinger is going to start this session with his talk on wound healing on the instillment plan. What's the payoff? So Chris actually needs no introduction. A former Almos Award winner, plastic surgeon, vascular surgeon, diabetic wound passion like never before, and I have to tell this story. Chris was late because he couldn't leave a patient, and to me, that's what this is all about, and that's who we are all about. Everybody in this room. So, Chris, I'm glad you made it, and we'll start with you.
Thank you very much. It's a pleasure to be here. My topic is addressed given to me by David, wound healing on the instillation plan. What is the payoff? The leopard asked the same question. Let me see. Here we go. So, disclosures, I work as a consultant for Saline, Smith & Nephew, and Integra, but I try not to make it affect the talk. So I'm going to talk about the role and potential shortcomings of negative pressure in wounds, and then what does instillation therapy bring to the table, what does the early literature show, and what's the current data. You all have seen this slide for a good almost 20 years. Negative pressure works by decreasing peri-wound edema, increases blood flow, increases granulation, and supposedly decreases bacterial count. It can be used every stage of reconstruction, should be used on debrided and on clean tissue, and should be carefully applied so that there's no maceration. The problem is this bacterial decrease, it really never decreases much below 10 to the 5, including in the early pig studies and subsequently in 2 randomized prospective studies. So you see that the bacterial count hovers around 10 to the 4 to 10 to the 6. And you can notice that when you change the dressing, you notice often that it stinks. The sponge tears at the dressing, leaving foreign body behind. David's paper showed a 17% infection rate in use of negative pressure for wound closure preparation. It may be a reflection of residual biofilm, and it can obviously lead to redebridement in preparation for closure. And this is one of the things we look for is slime in a wound. That's the obvious sign. Unfortunately, most of the time it's not that obvious. And all of us who work in the wound center are thrilled by when we look at a wound that we've just curetted. We feel, wow, we've done something good. But when you look at the actual bacterial count, you've only decreased it by half a log. So it's fairly inefficient just to treat the surface of the wound. And indeed, the study given to me by Smith & Nephew shows that the bacterial amass deep to the surface of the wound, and that's one of the reasons why it's hard to get a wound clean. That's why it stinks after you use the back for a while, is that bacteria surfaces. So how do you get rid of it? You can be draconian and just take it surgically, and the more you take, the less likely you are to leave residual bacteria, but you may not have a foot left. You can disrupt it by using lactoferrin, xylitol, iodosorb, surfactant, soap and water, electric current, ultrasound, shockwave therapy, and maybe negative pressure. So negative pressure with instillation we know negative pressure doesn't do it. What if we add an instillate to the wound and bathe the wound, and you can choose saline, antiseptic, or a surfactant, and you change it regularly. You flush that medium regularly. What does that do? Well, Fleischmann was one of the pioneers with negative pressure to begin with. In 1998, showed that in 27 wounds, using Lavacep or Nevacetin for 30 minutes several times a day for 7 days, was able to close 100% of these chronic wounds with only one recurrence of osteomyelitis. So that was pretty promising. Then Gabriel showed, in burns you use silver nitrate. It's very labile. You have to cover it with tin foil and you bathe the wound very short time. Well, that's a very hard preparation, but he got fantastic results by using instillation using silver nitrate. Note that the dwell time was 1 second, and he was able to decrease the treatment days by a quarter, decrease the infection by a quarter, took half the time to close the wound, 100% of the wounds closed, and the length of stay was half. So that's pretty dramatic. And then Timmers compared negative pressure with instillation compared to the old way of treating osteomyelitis, which was with beads. And the only question mark here is that he used pressures from 300 to 600 millimeters of mercury, which is hard to fathom. Anyway, he was able to achieve some excellent results with only 10% recurrence of the osteomyelitis versus 60% for the beads. He was able to do it in half the time, with half the hospital admissions, and with over half as many operations. So, again, promising. And then Lerner, looking at the most difficult of problems, is when you get an infected total joint. You know that a total joint may cost $25,000 to $30,000. If you get an infected total joint, multiply that by 10. So it's a disaster. So they essentially, in total hip infections, they infuse polyhexanide for 15 minutes every hour, and they saw whether they could retain the joint and just replace the plastic component of it. And they were able to save, in the early infections, which means less than 8 weeks, they were able to save 86%. This was subsequently substantiated by doing a prospective randomized study looking at various joints in various centers, and they were able, in that study, to be able to save 86% of acutely infected joints and 80% of chronically infected joints. Pretty remarkable. So we looked at that data and we said, okay, is this real or not real? And so so our protocol is fairly aggressive. We're a surgically based wound center. We will take a patient, we will get some pre-debridement cultures, not surface but underneath. We'll debride the wound, then we'll get post-debridement cultures, and then we'll put negative pressure with instillation, and that'll guide our therapy. If the cultures are negative, we'll close at the next stage. If they're positive, we'll keep debriding until we get negative cultures. And so this was a retrospectively analyzed data, which obviously doesn't have much validity, but we looked at 142 patients. We compared with historical controls where we just used negative pressure without instillation. And we did it in 3 periods. We did it first through September, and we looked at our data, and we found that the instillate that we were using was not effective against gram-negatives because we're instilling for 6 minutes. So we changed the protocol to 20 minutes. So negative pressure was applied 125 millimeters of mercury. There was 3.5 hours between instillates. And then it was later decreased to 2 hours. And the instillation was polyhexanide and betaine, the same material that they used for that remarkable joint paper. We initially used 6 minutes. We found it killed gram-positives, did not really kill gram-negatives. And so we then looked at the literature and found that if you increased the dwell time by 20 minutes to 20 minutes, you had a better chance of getting both groups. And this paper in the veterinary literature shows indeed that pontrasan or polyhexanide is really not as effective against gram-negatives as gram-positives, so explaining why our data was poor at 6 minutes. And so we had no difference in the demographics, no difference in the anatomical location between the historical controls, the 6-minute controls, and the 20-minute. And remember, this is retrospective and non-randomized, but we did show that we had about half we operated 1/2 less operation per patient in both the instillate groups. Our length of hospital stay dropped by about 2 to 3 days, and the time to final surgery where we closed the wound decreased by 2 days. Then we saw this interesting paper by Luc Théo, where in France you're not allowed to put polyhexanide as a topical instillate, and so they use saline. Now they had a very bizarre mixture of how they used negative pressure, without, post, without, etc. But the end result was using instillation before or after using regular negative pressure, they were able to heal 128 of 131 wounds. So it suggested that saline may have a role. So we then said, okay, let's look at saline versus polyhexamide and betaine. And we decided on 20-minute dwell time, and we decided to do it every 2 hours. And we admitted anyone who had a wound that required OR debridement, and we looked both at the intent to treat, that means all patients who entered the study, we're going to look at the data, and then those that were able to follow the protocol through the end, we're going to look at that data. We were 4 surgeons, single institution. So 100 patients were randomized, and we were able to, 83 completed the protocol, but we analyzed both the intent to treat and those who followed the protocol. There was essentially no difference in the demographics of both groups. There was no difference in the etiology of both groups. Let me just back up. The only difference was there were more males than females, sorry. And the wound location was mostly in the lower extremities, since that's what we do, but there are some in the back and the abdomen. So the outcomes, both the top chart shows you intent to treat, and the bottom chart shows you per protocol. And so you can see that the time to the final operation was still shorter than our controls. In the polyhexamide group, it was 7.73 days, but it was shorter yet if you used normal saline. And indeed, if you looked at just the per protocol, it suggested also that the length of stay was shorter by using normal saline. So the limitations of the study showed that there was no control group, obviously. The surgeons were unblinded as to the instillation solution. The determination of when to close was variable, and the wound size was not documented. But the qualitative cultures were so incoherent that we really couldn't come up with any good explanation, and that's why we're looking forward to the results of this prospective randomized study. Remember, the previous study was unfunded. This is funded by Acelity so that we can actually get quantitative cultures and PCR data on all these wounds, and we may be able to come up with some better explanations. So I wanted to make this talk short because I realize I'm working on borrowed time. But in the conclusion, negative pressure with instillation appears to be more effective than negative pressure in preparing a surgical wound for closure, in terms of number of operations required for closure, time to closure, percentage closed, and length of stay. And more interesting, saline appears to be at least as effective as polyhexamide with betaine. So you may drink the Kool-Aid like we have and think that instillation therapy is the be-all and end-all, or you may want to run away from it as fast as you can. I think we need good randomized prospective study to be able to determine which way to go. Thank you very much.
Thank you, Chris. To move right along, Professor Lipsky, we're going to hear from General